This is a recording for chapter 30. We're going to be talking about hematological or hematologic disorders. The first one I want to talk about is anemia. So we're going to talk about anemia. And basically, anemia, you're going to see a deficiency in your erythrocytes. Also, there's a deficiency in the quality of your hemoglobin and your hematocrit, which is your volume of packed RBCs. So, going to be a deficit there. These are some etiology, some causes of anemia. Again, like I said, you will see a decrease in the production of your let me maximize this thing so I can see it. Y'all give me just a second. Okay. You're going to see a deficiency in your RBC production. Also, blood loss. As you can see here, trauma would be an issue that could cause a deficit in your cause of anemia as well. Uh, as far as the anemia again, you also going to be looking at the relationship of different how it's diagnosed whether under the microscope they look at the etiology or the morphologic classification of the causes of anemia, and again it's based upon how they are shaped, those red blood cells are shaped under the microscope. Okay. Again, some causes, some clinical manifestation that you will see rather. Again, anemia, you're going to see some change in skin, respiratory changes, shorter breath, some muscular changes, muscular weaknesses. So look at that little chart there. It's going to give you some clinical manifestations of things that you're going to see. And then again, it's going to, oxygen is carried by the blood, the RBCs and oxygen rather. So again, going to be a deficiency there. Hemoglobin, again, this is how we determine the severity of the anemia by looking at the hemoglobin level as well. Um, as like I said, looking at that little chart as we break it down, looking at the man from the integumentary, the skin, again, based on you're going to see paler in all types of anemia due to the decrease in the hemoglobin level and also blood flow to the skin. So again, blood is not flowing to the skin, so you're going to see that paler color. Jaundice, again, look checking the sclera. Jaundice is due to also increase in RBC destruction. And then you're going to see increase in your billy level, which is going to cause the eyes to be yellow, and sometimes the skin could be jaundice as well. And then pruritus, itching, due to an increase in RBC destruction. Uh, Itching, as you can see there, due to the increase in the serum and bowel salt concentration as well. From the heart perspective, the cardiopulmonary perspective, you're going to see a low blood pressure, heart rate is going to be elevated, increasing your stroke volume. The client could have murmurs, bruits, chest pain. They can also have an MI or congestive heart failure due to some the anemia. So again, when you're assessing the client based on the cardiovascular system, these are some clinical manifestations you're going to see. These are different types of anemias, and we're going to talk about them. Iron deficiency, thalassemia, microcytic, megaloblastic, due to vitamin B deficiency and folic acid, aplastic anemia or pancytopenia. Penia meaning these clients are going to be at risk for infection. There are also, we talked about looking at the little slide earlier, the chronic acute blood loss, sickle cell, hemolytics, and also anemia due to chronic diseases as well. Iron deficiency, let's kind of look at it. It's the most common iron deficiency anemia. You need to remember, it's the most common chronic hematologic disorder. Iron deficiency could be related to inadequate intake of iron, malabsorption issues, chronic blood loss again. And again, like I said, just looking at the shapes of the under the microscope, determine which type. Um, Iron therapy. How do we replace it? Okay, we're gonna make sure we know that iron is best absorbed in an acidic environment. Okay, it best absorbed in the duodenum and also the proximal jejunum. So again, we're going to give supplemental, could be 100 to 200 milligrams of iron elements. So again, we know giving iron, it stains the teeth, so we need to give it undiluted with a straw. And then also it could stain the skin. So with that being said, how will we give it IM? Okay, Z-track method, because it could stain the skin, so we're going to get it deep into the muscles, okay? Some side effects of the iron supplement therapy could be heartburn, constipation, tarry stew. Now we definitely need to tell our clients, check your stools, let them know it could be dark, okay, so they won't get alarmed. Okay, they could get constipated due to the iron, so they need to be on a stool softener, the Colace, they could buy it over the counter. Um, Again, IV iron may be required a test though, because it could be a client could be allergic to it. So they're gonna test them to just give them a small dose to make sure they're not allergic to the IV. Okay. So again, remember the stained teeth, um, the constipation, Z-track method when we're giving iron. Let's talk about another deficiency, thalassemia. It's a genetic disorder, and this is where clients will have an inadequate production of normal hemoglobin. You see it mostly in your Mediterranean population. Okay, megablastic. It's caused by DNA synthesis. This is where you're going to see a large presence of large fragile RBCs. Like I said, again, the shape of the cell going to be determined the cause. Okay, and what type rather, the type. So cobalamin or vitamin B deficiency is due to could cause metabolic anemias, megoblastic, I'm sorry, folic acid deficiency, so B12 and folic acid. And then again, based on the shape, you're going to see an increase in the MCVs and normal MCHs. Again, we're still looking at the shape here. So megablastic, cobalamin, deficiency could lead to pernicious anemia, and then also megablastic could also lead to folic acid deficiency. The Schilling test is used to diagnose pernicious anemia. Again, this is what we how we diagnose. Nuclear medicine, that's how they do it. They use a nuclear medicine. They give cobalt tag B12s. Then they inject IM injection of B12 also. Then they can do a 24-hour urine test. Once this is all part of the Schilling test, okay? So they use this to diagnose. They use nuclear medicine. They give cobalt, tag or vitamin B12, IM injection of regular B12, and then they do the 24-hour urine. Chronic diseases can also lead to anemias, underproduction of RBCs. Usually, a mild anemia can become severe if it's not treated. So if it's not treated, it can lead from mild to severe, and these clients could die due to complications. Okay, well, like we just said, heart attacks could be a cardiovascular complication. Aplastic or pancytopenia. This is where you're going to see a decrease in all of your cell types. Okay, and usually aplastic or pancytopenia is usually congenital due to a chromosomal alteration. It can be what we call idiopathic. We don't know what happened, why, or it could be due to a chemical agent or toxin. It could be related to drugs, radiation, viral, bacterial infection. Okay, so again, all of your RBC is going to be abnormal, a decrease in all of them. It also could be congenital due to chromosomal, and like I said, it can be acquired, viral, bacteria, drugs, toxin, radiation, and our idiopathic. We just don't know what the cause. So again, when we're looking at clients that have had acute blood loss, these are if they lose any less 30% or more blood, as you can see, normal it could these clients the blood pressure and pulse rate at rest. They may have hypotension or okay, tachycardia. So yeah, 40% loss, you may, I'm sorry, let's go back. 10%, you may not see any clinical manifestation. 20% of blood loss, not, you may not see any detectable signs and symptoms at rest. But then again, on the exercise, when they moving around with 20% blood, they may get tired. They may have postural hypertension. Heart rate is going to be elevated. But look at 50%. They can go into shock. They could potentially die. Okay. So again, with a 30% blood loss, you're going to see if the pulse and the blood pressure could be normal in a supine position. Okay. But again, when they get up, they can have some postural hypotension and tachycardia when they're moving around. But supine, 30%, you're going to see a normal vital signs. Sickle cell anemia. It's the genetic also. It could result in sickling of the cells. As you can see on the slide here, you see how those cells are sickled. Just they're named by the sickle cell is named by the shape of the cells. And think about those cells sickling, how they are trying to get to the capillaries here, and you're gonna see some occlusion there. So the occlusion is what caused the pain. And then remember, they do not carry oxygen to the cells because they become hypoxic because they can't get through the blood cells can't get through the cells here, so it's going to occlude, so they're not going to get oxygen. So what will be initial treatment for these clients when they present? Remember, oxygen is it's a pain management. So once we get them oxygen, if they present, also, we're going to start an IV and hydrate them. So we're trying to get those cells from sickling. So again, that's what really caused the pain, the sickling, the shape of those cells. These are some other clinical manifestation of sickle cell as well, as you can see here. Again, like I said, the pain is going to be a big clinical sign. They could get fever. They can get infection. The lungs, again, they can have respiratory. So they really present shorter breath. So as you can look at the chart here, look at all the clinical manifestation there. And then you have acquired hemolytic anemia, which is due to extrinsic factor, meaning something that affects the body outside of the body. It could be related to trauma, antibodies, autoimmune reaction, and again, infectious agents and toxins as well. Also, as we look at the some other events of hemolysis, the blood kind of hemolyzes, it kind of clots up. So again, as a result of that, you're going to see jaundice. The spleen could be enlarged as well. So again, that jaundice is going to be due to your RBC is going to be destroyed, which is going to increase your bilirubin level. So definitely you need to look at the bili level for these clients. Hemochromatosis, it also genetic. It could be the primary cause, and it leads to increased iron absorption and iron overload, primarily the cause. Then it could be due to secondary, which would be overload from liver or diseases. A client getting multiple drug transfusion also can have hemochromatosis. That's an iron overload, okay? Then, like I said again, genetic, and then also a problem with absorption. Some causes of hemochromatosis could be liver failure, cirrhosis, skin changes, cardiomyopathies, arthritis, and then hepatic, cellular cancer, so liver cancer. How we treat these clients, we can do chelating agents like this Vesperol, and also phlebotomy, where they go in and remove some of the blood. And when they remove it, like I said, that could decrease the iron overload. Polycythemia. This is where you're going to see um, hyperviscosity. The blood is going to get thick, really thick. And also you're going to see hypervolemia. It's rare. So again, primarily you may it's called polycythemia vera, and then secondary it could be related to again decrease in oxygen, and you're going to see an increase in estrogen. So again, hyperviscosity, again, thickening of the blood. And the blood that's get thick is not going to flow through the capillaries, so you're going to see hypoxia. Some clinical manifestation you may see, several, and I'm not going to name them all, but you can kind of look at those. So headaches, vertigo, tinnitus, problem with the sight, the spleen and the liver could be enlarged. The client could be itching, thrombocytopenia, thrombophlebitis, I'm sorry, gout, paresthesia. So these are some of the clinical manifestations you may see. Again, how we treat it, like I said again, you want to do a phlebotomy. We're trying to get that hematocrit less than 0.45. And also, we can give aspirin as a blood thinner, Plavix, or Clavita gel. It's also a blood thinner. Also, these clients may benefit from a cyto reductive therapy, which could be hydroxyl, will be your first line treatment here. Interferon. You're going to give this to clients that are less than 40 years old, those pregnant clients, and those clients that continue to have itching or pruritus. So again, interferon and hydroxyurea are going to be your treatments beside the phlebotomy. So again, what are the nursing responsibilities with polycythemia? We need to assist with the phlebotomy. These clients need to be on a strict I&O. We need to give them medicine as ordered, teaching them about the disease and about the drugs, the medication treatment. Activity, encourage them to exercise. We may have to provide range of motion and do leg exercises. Thrombocytopenia is another disorder. You're going to see ITP, TTP, and HIT. And so we're going to look at each one of those separately. Hemophilia, von Willebrand disease, and DIC. Thrombocytopenia, basically, you're going to the blood cell count, the platelet count, I'm sorry, is going to be less than 1 to 50. Thrombocytopenia can be inherited or could be acquired. And usually, if it's acquired, it's due to the client is on myelosuppressant drugs, could be foods, herbs, or things of that sort. ITP again could be due to infection, H. pylori. So clients that have tested with H. pylori, they're going to be put on that regimen, viral or H. pylori rather. It's a very harsh regimen that they need to take the entire course because if not, they can develop ITP. DTTP is basically due to drug toxicity, pregnancy, preeclampsia. And then HIT, that's heparin induced. This is a complication of heparin. Those clients that have been on heparin drips, they're going to be at risk for HIT. HIT and DIC, these clients could bleed out very quickly. Okay, so you need to remember HIT, DIC. And this is what the skin looks like with a client with thrombocytopenia. You see that little petechiae. That means that they are bleeding in the capillaries there. There's blood under the skin. And that's on that last picture slide down to that purple arm light. That's a client that's been on heparin. So that's, you will see that too in the clinical setting. That's what HIT looks like. And then, so with that being said, we need to handle these clients with caution, teach them safety measures, brushing their teeth with soft toothbrushes, using an electric razor, teaching them to monitor their outputs all from all orifices for any blood. Okay. So again, these are I kind of got a little bit ahead of myself. So you're going to monitor for signs and symptoms of bleeding, for thrombocytopenia, monitor your coagulation studies, which is your PT, PTT, platelet, D-dimer. We don't want to give any IM injection because again, they're at risk for bleeding. And I told you about the razor, protect them from trauma. They may have to have blood. Also, these clients need to be taught to avoid any high impact activities. Educate them on the disease and treatment. Hemophilia and von Willebrand disease, it's basically genetic disorders. This is where these clients will have a defect in clotting, defect or deficiency in clotting time, meaning that they can bleed out very quickly. So we need to with these clients we need to be monitoring their um, platelet count again. It's going to be similar to go back to the previous slide. The nursing manager is going to be similar to that of thrombocytopenia. Like I said, they're going to be at a high risk for bleeding. So these factors that you see that below there, your factor 9, your factors 8, in platelet dysfunction, this is how we are diagnosing these clients. They're going to be a deficiency in these factors. So your clotting factors. DIC, or disseminated intravascular coagulation, is not a disease, but is an abnormal serious bleeding and thrombolytic response to clotting cascade. These clients, they bleed and clot at the same time. So they bleed, they clot. So again, they're going to be at high risk. They hemorrhage. That's going to be severe. It's very severe. Like I said, they could bleed out. They have massive thrombosis. Now, with that being said, these clients, when they start bleeding, they're going to be bleeding from all orifices. Okay, ears, eyes, everywhere. So they are very critical. So it's a cascade effect. And this basically is like an algorithm here. You can look at that for DIC. So with that being said, with DIC, you need to monitor these clients for bleeding. The heparin may have to be stopped. Okay, so those were some platelet dysfunction, RBCs, and now we're going to look at some WBCs disorders. Leukopenia. This is where you're going to see a decrease in your WBCs, your granulocytes, monocytes, lymphocytes. And then also you're going to see a deficit in your neutrophils, eosinophils, and basophils. You're going to see an abnormal in your ANC, absolute neutrophil count. So the normal ANC is 4 to 11,000. If a client ANC is less than 1,000, they're going to be at a high risk for neutropenia. So these clients need to be on neutropenia precaution. There needs to be a sign on the door: no fresh fruits, no flowers. Now they can eat fruit, but they cannot be fresh fruits. A lot of times the students get confused, saying they can't have fruits or fresh vegetables. They are vegetables. They can have them, but they can't be fresh. Severe neutropenia is anything less than 5,000. So these clients are at high risk for infection, and they die as a result of infection. So there needs to be a sign on the door, visitors warning everybody to wear masks, wash their hands before entering the room. Strict aseptic techniques when handling these clients. How we manage these clients, again, monitor them, like I said, fever. They develop it's a medical emergency. They need to be on antibiotics, and they need to be started within an hour. Okay? They may have to have some Neupogen, Leucine, Neuralast. Again, they may be on prophylactic antibiotics, empiric. But then we also those antibiotics that they on, we need to definitely be watching if they have therapeutic ranges, like your myosin drugs, which are very harsh on the kidneys. We need to be monitoring those therapeutic ranges. Okay. Leukemia. Leukemia again is you may see where it's described as malignancy of the blood forming tissue, lymph system, the spleen, meaning that it can spread to all of these organs. Okay, leukemia is just classified as acute or chronic, and it could also be a result of the origin of your RBCs WBCs could be involved as well. This is a pathophysiology of leukemia. You can kind of look at that algorithm. What are some clinical manifestation? Again, bone marrow failure. for one. These clients, they may benefit from a bone marrow transplant if they're good candidates. This they're going to have inadequate production of your normal marrow elements, okay? So therefore, they may be good candidates for implant, a bone marrow transplant. I'm sorry. Some causes of leukemic cell could cause the spleen to get enlarged, the liver, the lymphatic system. These clients can have bone pain, meningeal irritation, oral lesion. They can have some solid mass also. Treatment, these clients may benefit from chemo, radiation. Like I just kind of told you earlier about the hemopoietic stem cell transplantation. This this is where they go in, they find a match, um, and they do testing and make sure that the client is a good candidate and make sure the donors are the good match also. Um, Autologous, meaning that they harvested from the patient from the patient prior to before they start the therapy on this client. They can do an autologous harvest, or they can do it from get a donor that matches or from an identical twin. Okay. Now I mentioned about the bone marrow aspiration is then also apheresis is where they go in, that you can see here. Apheresis is where they harvest the stem cells from the peripheral blood, and it's similar to something like when the client is on a dialysis machine, but it goes through that kind of cycle. So they harvest the stem cells from the peripheral blood. So the overall nursing goals for leukemia, we want to help the patient understand and comply with the regimen. We want to minimize any side effects, any complication. Teaching the family, trying to get the clients in remission, prevent them from relapsing. And then, like I said earlier, make sure they're on neutropenic precaution. Lymphomas, it's a malignant neuroplasm. It starts in the bone marrow, and then it also can get into the lymphatic tissues. There are two major types, Hodgkin's and non-Hodgkin's. As you can see here, when you're comparing the two, Hodgkin versus non-Hodgkin, Hodgkin lymphoma, you're gonna see some B cell lymphocytes, and also with non-Hodgkin, you're gonna see also T cell. The T cells or natural cells gonna be compromised. Okay. Um, Also, when we classify them, we comparing the two. With Hodgkin disease, it's Hodgkin lymphoma. Rather, it's usually localized. It's localized to regional, but it may not be widespread. But meaning that it may be in one area, just localized there. But as far as non-Hodgkin, it can be disseminated, meaning it can spread. Okay, I'm sorry. Let me go back. Hodgkin disease is localized to regions, but it may be widespread. Okay, non-Hodgkin is disseminated. It's automatic. It's gonna spread. Uh, with the clients with Hodgkin, the B symptoms are common, and then and also extranodal involvement, like it's rare because we just said it's usually regional, it's localized. Um, and with non-Hodgkin, it's uncommon also for those B symptoms, which is going to be like a fever, things of that sort. So let's go back and look at. I think I have a chart here, but if not, it's in your book. Looking at how it spreads lymphoma. Again, like I said, if it's regional, it's usually confined to that region. But once it hits the lymphatic system, it can be widespread, meaning it can impact all major organs or all organs because it's getting the lymphatic system, so it's spreading. Some common causes really unknown, but some key factors could be the infection with the Epstein-Barr virus, could be genetic. Also, exposure to occupational toxin. If y'all watch TV, watch the news, that mesothelioma, it could be related to the ground up. So this is why we ask clients, what's your occupation? What do we work? What do you work? So again, we can try to determine the cause of these lymphomas. Also, the diagnostic test, the hallmark diagnostic test. This is what you're going to be looking for. This is going to help with the diagnosis. That Reed Steinberg cell, and they do a biopsy of the lymph nodes, and they look for those Reed Steinberg cells in that specimen. So you need to remember that. That's a hallmark feature. And this basically, you see the Hodgkin here where it's kind of localized. You see that lump in the back there, right there. So it's kind of like it's kind of localized right there. Okay. And then this is the picture that I was talking about right here. So as you can see here, stage one, and you see that node, the nodule up in the neck, and then stage two, now it's gotten in the lymphatic system, so it's spreading. So it's down in the breast right there. And then as you see here, stage three, it become more widespread. And then stage four, as you can see, it can get in the bone marrow, get in those organs. Okay? And like I said, going back to those B cells symptoms, you're going to see fever, night sweat, weight loss. You need to remember the B cells, B cell symptoms rather, the B symptoms: fever, night sweat, weight loss. So you see how that lymphoma has spread it there. Um, Going back to some clinical manifestation, I told you those nodules, they're usually painless. And I told you they have those, the clients have chills. I told you about the fever. The fever with the B symptoms, again, the fever get greater than 100.4. They have drenching night sweat. Weight loss, they lose about 10% in 6 months of their weight. Mediastinal nodules involve symptoms. These clients cough, they have dizziness, stridor, and dysphagia. Now, as you can see, if a nodule is in the mediastinal um, area, it's going to compress on the um, diaphragm. The diaphragm could cause coughing, could cause pneumonia because you're compressing on that. So these clients usually die from respiratory complication. And whenever a client drink alcohol, they have alcohol-induced pain as well. Again, these clients may have itching. The spleen and the liver may be enlarged. They may develop anemia. So again, other symptoms may depend on the location of the disease. But like I said again, on that diaphragm, you're going to have some difficulty with your respiratory system. So you need to remember the B symptoms, okay? Non-Hodgkin's again is a heterogeneous malignant neoplasm. It could affect all ages. Primarily, it's going to be a B and T cell origin. Causes with this is really unknown. But however, it's usually you see it more commonly in those clients that use those immunosuppressant drugs, or they've got chemo or radiation. Because what they do, the drug decreases the immune system, put them at high risk. There are really no hallmark features for non-Hodgkin's. However, these clients again, they may have those painless lymph nodes. They be enlarged. Those are your primary clinical manifestation. And these nodules or these they can originate outside of the lymph node, and the spread again could be unpredictable. Again, if you have nodules like in the area of the throat, the esophagus, you see how the airway could be obstructed. These clients can go into renal failure. They can have pericardial tamponade, GI complaints. But the prognosis for a non-Hodgkin is not as good as that for Hodgkin disease. So the prognosis is usually poor. But like I said, these clients have a hallmark. They could airway obstruction, and they can go into have hyperuricemia, renal failure, GI problems, cardiac problem. They could die. So with the nursing management for lymphomas in general, we do the therapy. It must be aggressive. These clients need some psychological counseling. Talk about fertility issues because we just said it could be genetic. So we want to talk about fertility issues. So we need to monitor the disease and also the side effects of the therapy. We know those clients that are getting chemotherapy, they can have alopecia, they may have nausea, vomiting, fatigue, and then radiation. Again, they could have skin irritation and things of that sort. Skin care during radiation, as we talked about, some of the complications. We need to avoid any lotion except that's approved by your therapist. So the client can just go out and buy some ornament or something. So because it can further cause some exfoliation of the skin or skin breakdown, they need to avoid the sunlight because the sunlight can aggravate. Because if you ever seen a client with radiation, skin is kind of red and it's very fragile. So skin light could cause it to burn even more. They need to wear light clothing, loose fitting clothing to avoid any chafing around the area. Nothing hot or cold or hot bath. It can also damage or further cause skin for fragile or for. So again, nothing hot or cold. No oils or ornaments. We need to inspect the skin every day. Report any changes to the therapist. Teach the client do not rub the skin, so we just pat it dry, mild soap. You don't need to use any antimicrobial soap, nothing really harsh, no deodorant if they're receiving chemo under the arm because it's gonna cause further skin breakdown. So these clients you want to teach them they can use uh kind of pat dry with their hand. They don't really need anything harsh on that skin. Okay, like I said, avoid sunlight, nothing hot or cold. Okay, can further cause some skin fragility. And they need to wear long sleeves if they're going outside, but they need to be loose fitted because we don't want any direct contact with the sun. Multiple myelomas, also known as plasma cell myeloma. This is where those malignant cells get in and infiltrate the bone marrow. They destroy the bone marrow. And you see it a lot, commonly in African American men over the age of 40. The cause is really not known, but it could be environmental, could be genetic, or could be due to a viral infection. And how we test for multiple myeloma, we do that Benz-Jones protein test. So the presence of Benz-Jones is a good indicator, a diagnostic test rather. Clinical manifestation, these clients will have skeletal pain, osteoporosis. Like I said, that the bone is being destroyed. Radiculopathy also could be some clinical manifestation that we see compression on that vertebra. Anemia, thrombocytopenia could be a clinical, and neutropenia. Hypercalcemia, which could lead to polyuria, anorexia, confusion, arrhythmias, seizures, and comas. These clients can also go into renal failure. So skeletal pain is a major manifestation. So again, how we manage these clients, we want to keep them well hydrated, monitor their intake and output because we just said they're at risk for renal failure. Monitor electrolytes, kidney function. They can analgesic for pain. They need to avoid any trauma because it can cause bleeding and fractures. And if they have multiple myeloma, they need to get prompt treatment for infection because they become systemic and they could die as a result of the infection. So prompt treatment, antibiotics, hydration, extensive monitoring of the kidneys function, INOs, and monitor electrolyte imbalance. The last thing I want to talk about real quick, and I hope you watched the video, done your ATI assignment on blood transfusion, administration procedures. We always have to check the orders and get the consent first. That's the first thing you want to do. Verify your rights. You need another witness. We want to, when we're starting blood, we want to use at least a 20 gauge or something larger because the blood is kind of thick. But in an emergency situation, you're going to get in what you can get in 20, 18, 22, whatever you can get in. You're going to use a wide tubing with a filter on it for each unit. If the client has 2 units of blood, you're going to get changed every time you give a unit. You're going to change the filter, the tubing. Normal saline flush only. Okay. If you use any dextro, it will destroy your RBC's lysis. So only normal saline. You're going to get your baseline vitals. You're going to check, once you get baseline, you're going to check your vitals 15 minutes, 30 minutes, and then every hour until that blood is completed. Once you get that blood from the blood bank, you need to start it within 30 minutes and you need to finish it within 4 hours. Okay? Do not give any additive with blood, meaning that you got to give potassium. You want a different IV site. Antibiotics, you don't want to run them through the same IV port. Do not handle it roughly because it can also cause hemolysis of the blood. You want to stay with that patient for the first 15 minutes. You're going to be monitored for any blood transfusion reaction. And some of those could be um, febrile reaction, allergic reaction, circulatory overload. You don't want to give it too fast because you can put the client in overload. Okay? They could have also delayed transfusion reaction, infection, transfusion related lung injury. Again, they can get, like you want to monitor these clients very, very closely. Back pain would be some other thing that you could look for, some reactions. Headaches. A lot of times students miss back pain. Flushing of the skin, fever, chills. Hyper or hypotension. Chest pain, tightness, itching, hives, shortness of the breath. If these clients start developing any anaphylactic reaction, you need to stop the blood immediately. Stop the blood. You're going to get a little pigtail off the port of that blood and take it to the lab because they need to check that. If client developed, make sure the blood was good. So again, take it back to get a little port. You see the little pigtail ports on the tubing, on the bag rather. Take it, stop the blood, notify the healthcare provider, and make sure you have Benadryl available. The urine may also be dark or black. These are all clinical manifestation of transfusion reactions. Okay, this ends this presentation for chapter on hematological reactions. I'm going to upload this in the form of a YouTube video to make sure it uploads. Okay, if you have any questions, please reach out and let me know. Thank you.